Hello everyone. Today we will begin to learn the orthopedic disease of the backbones of extremities. The backbones of extremities mainly include humerus, fibula, of which radius and ulnar, as well as tibia and fibula, are double bone structures.
First of all, we will learn the anatomy of backbones of extremities. The humerus is a long tubular bone of the upper arm, divided into two ends. The hemispherical articular surface that enlarges at the upper end and protrudes medially and superiorly is called the humeral head, which forms a joint with the glenoid of the scapula. The lower part of the head is slightly thinner, which is called the anatomical neck. An eminence that laterally protrudes from the head is called the greater tuberosity. Below the humeral head is an anteriorly directed apophysis called the lesser tuberosity. The bone ridge extending down along the greater and lesser tuberosities are called the greater tuberosity ridge and lesser tubercle ridge, respectively. The sulcus between the greater and lesser tuberosity ridge is called the intertubercular sulcus, and the long tendon of biceps passes through it. The transition between the upper end of the humerus and the body of humerus is slightly narrow, called the surgical neck, and is a predilection site for fractures. There is a rough surface on the anterior lateral surface of the medial of the body of humerus, called the deltoid tuberosity, which is the deltoid stop. The medial of the posterior aspect of the body of humerus has a spiral shallow sulcus that is obliquely outwards and inferiorly from inside to outside and slightly turns anteriorly, which is the pathway of the radial nerve. The lower end of the humerus is enlarged and slightly flattened anterior-posteriorly. The lateral part is small and hemispherical, called the capitellum, which forms a joint with the radial head. The medial part is large and has a torcular articular surface, hence called humeral torcular, which forms a joint with ulnar torcular notch. There is a coronoid fossa in the lower anterior end above the torcular, and a radial fossa above the capitellum, which accommodates the coronoid process of the ulna and the radial head, respectively, when the elbow joint is flexed. There is a deep fossa in the lower posterior end above the torcular called the olecranon fossa, and the olecranon of the ulna protrudes into the fossa when the elbow is extended. A nodular eminence on both sides is called the medial and lateral epicondyles, respectively. The medial condyle is large and significant, with a longitudinal superficial sulcus behind it, which is the pathway of ulnar nerve, so it is called the sulcus for ulnar nerve. Next, let's take a look at the muscles of the humerus. The upper 1/3 anterior lateral humerus is attached by the deltoid. The lower 2/3 is attached by the brachialis, the medial by the coracal brachialis, and the posterior by triceps brachii. The biceps brachii originates from the scapula and the coracoid tip and descends to cover most of the brachialis. For the neurovascular distribution of the humerus is mainly nourished by brachial artery and deep brachial artery. The brachial artery descends into the cubital fossa along the medial bicipital sulcus, and the height of the flat radial neck is divided into the radial artery and ulnar artery. The main branch of the brachial artery is the deep brachial artery, which runs in the sulcus for radial nerve, and it is distributed in the posterior arm muscle group and the elbow joint. The cephalic vein is located at the anterior lateral border of the deltoid and within the intermuscular sulcus of the pectoralis major. The lateral side of the triceps brachii is a median nerve. The medial side is an ulnar nerve. The median nerve descends through the anterior brachial artery to the medial biceps brachii. Then we proceed to learn the anatomy of the femur. The femur is the longest tubular bone in the human body and also has a two-end integrated structure. Its upper end faces medially and superiorly, and the end enlarges and is spherical, called the femoral head, which forms a joint with the acetabulum. There is a small fovea slightly below the center of the head, called the fovea of femoral head, which is the attachment of femoral head ligament. The thinner part of the lower lateral side of the head is called the femoral neck. On the lateral side of the neck junction, there is a superior eminence called the greater trochanter, and a smaller eminence below it called the lesser trochanter. The medial surface of the greater trochanter has a depression called the trochanteric fossa. Between the greater and lesser trochanters, there is an intertrochanteric line anteriorly and intertrochanteric ridge posteriorly connected. The corpus femoris is stout, cylindrical, slightly convex anteriorly, smooth anteriorly, and has a longitudinal bone ridge posteriorly, called the linea aspera, to which the muscle attach. The linea aspera can be divided into medial and lateral lips. The two lips are close to the middle of the corpus femoris, while the upper and lower ends are gradually separated. The lateral lip moves superiorly and laterally and forms the gluteal tuberosity, while the medial lip moves superiorly and anteriorly and ends at the lesser trochanter. There are two enlarged eminences in the lower end of the femur curling posteriorly, which are called the medial and lateral condyles respectively. There are articular surfaces in the inferior and posterior surface of both condyles forming joints with the upper end of the tibia, and the anterior articular surface is connected to the patella known as the patellar surface. Posteriorly, there is a depression between the two condyles called the intercondylar fossa. There is a rough eminence on the medial surface of the medial condyle and the lateral surface of the lateral condyle, respectively, called medial epicondyle and lateral epicondyle, respectively. There are three groups of muscle around the femoral shaft, of which the quadriceps femoris, innervated by the femoral nerve, is the largest, followed by the hamstring muscle, innervated by the sciatic nerve, and the adductor muscles, innervated by the obturator nerve, is the smallest. The sciatic nerve and femoral artery and vein are close to the femur at the lower one-third of the femur and descend to the popliteal fossa, which are most susceptible to injury if fractures occur. Next, we will learn an anatomical characteristic of double bones. First of all, let's take a look at the ulna and radius. The ulna and radius are connected with annular ligament, interosseous membrane, distal radial ulnar ligament, and triangular fibrous bone to constitute the proximal radial ulnar joint. Forearm interosseous membrane and distal radial ulnar joint, which play an important role in the rotation and stability of the forearm. There are mainly ulnar nerve, radial nerve, and median nerve passing. The upper end of the ulna is thick, and the lower end is thin, which is an important part of the elbow joint. The upper end of the radius is thin, and the lower end is thick, which is an important part of the wrist joint. The normal ulna is the axis of the forearm and is connected to the radius through the proximal and distal radial ulnar joint and the interosseous membrane. The radius rotates along the ulna and spins to the pronation position with an amplitude of up to 150 degrees. There are many forearm muscles, mainly including flexor and extensor muscle groups, pronator and supinator muscle groups. The interosseous membrane is a dense fibrous membrane whose tightness changes with the rotation of the forearm. In the neutral position of the forearm, the two backbones are close to the parallel, with the largest backbone space, and the interosseous membrane is tightened up and down consistently, which plays a stabilizing effect in the radius and ulna. When in the pronation and the supinator position, the backbone space decreases. The interosseous membrane is tightened up and down inconsistently, and the stability between the two bones disappears. Next, let's learn the structures of the shafts of tibia and fibula. The tibia is located on the medial side of the lower leg. The fibula is located on the lateral side of the lower leg. The tibia is the main part. The upper end is connected to the lower end of the femur alone. The fibula is not involved in the composition of the knee joint, but connected to the lateral side of the tibia with amethyarthrosis and ligament. But the lower ends of both bones are involved in the composition of the ankle joint. The upper end of the tibia enlarges and forms the medial and lateral condyles, which form the knee joint together with the medial and lateral condyles of the lower end of the femur and the patella. The bone surface protuberance between the two condyles is called the intercondylar eminence. The anterior side of the upper end of the tibia has a rough eminence called the tibia tuberosity, which is the attachment of the quadriceps femoris. There is an articular surface on the posterior inferior side of the lateral condyle, which is connected to the fibular head and is called the fibular articular facet. The anterior border of the shaft of tibia is particularly sharp and called the anterior tibia crest, which is palpable on the skin surface. The lower end is enlarged, with the articular surface attached to the talus below it and a downward apophysis on the medial side, called the medial malleolus. There is a triangular depression on the lateral side that connects to the fibula, called the fibular notch. The fibula is slender and also divided into two ends of the body, and its upper end enlargement is called the fibular head, which is palpable on the skin surface. There is an articular surface in the upper part of the head that forms a joint with the articular surface outside the upper end of the tibia. The thinner part below the head is called the fibular head. The shaft of the fibula is slender, and its interosseous ridge is opposite to the tibial crest of the same name, which is attachment of the interosseous membrane. The lower end is slightly enlarged and is called the lateral malleolus. The inner surface of the lateral malleolus has a triangular articular surface, which forms the glenoid fossa together with the articular surface of the lower end of the tibia and forms a joint with the talus. According to the special examination, we have a preliminary diagnosis on the injury of backbones of extremities, and then we will learn the imaging-related knowledge of backbones of extremities.
Well, that's all for this lesson. I hope you can actively review it after class. Thank you.